So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, on the occasion of the World Alzheimer's Day, the IVPN NeuroPsychiatry, in collaboration with Biogen, is organizing this educational activity entitled The Treatment of Alzheimer's Disease, Are We There Yet? In order to spread awareness, educate, and demystify dementia so we can improve the quality of life of people living with Alzheimer's disease. Alzheimer's disease is a progressive and irreversible neurodegenerative disease, and it corresponds to the most common cause of dementia worldwide, accounting for 60 to 80% of all cases. And epidemiological studies indicate that Alzheimer's disease will become even more incident by the mid-century, constituting a major personal and societal tragedy. Despite scientific breakthrough during the past decades that have expanded our knowledge on the cellular and molecular basis of Alzheimer's disease, therapy that effectively halt the disease progression are still lacking or very few. And focused efforts are needed to address this public health challenge. In June 2021, the FDA approved aducanumab, the newest clinical treatment for Alzheimer's disease in nearly 2 decades. I will not say more, and I will leave the floor to our speaker, who will tell us more about this novel targeted therapy and will also discuss the pathophysiology, diagnosis, and management of Alzheimer's disease. But before starting, let me thank Biogen for sponsoring this educational activity. Our session will be delivered tonight by the expert in the field, Professor Shaqra, who is a consultant neurologist at Sheikh Khalifa Medical City, Abu Dhabi, UAE. Professor Mustafa Shaqra has particular interest in inflammatory and degenerative disease of the central nervous system. He ran the clinics of the multiple sclerosis at Sheikh Khalifa Medical City. Professor Shaqra has graduated from Medical School of Damascus University in 1992 and received his main training in general and internal medicine and in neurology subspecialty in the major university hospitals. He carries MD, a master's degree, MRCP, and FRCP in medicine and in neurology. And additionally, he has authored and co-authored many articles in the field of neurology. Professor Shaqra, we are always honored to have you as a speaker with us. Welcome, and the floor is yours.
Thank you, Maya, for your kind introduction, and thank you, IVPN. Thank you, Biogen. And good evening, my friends, my colleagues all over the world. My name is Mustafa Shaqra, and I'm a neurologist at Sheikh Khalifa Medical City in Abu Dhabi. So let me first share my slide. Is it okay, Maya?
Yeah, we are seeing perfectly your slide. You can go ahead, Doctor.
So the topic today is gonna to be into 2 parts. We'll go into 2 parts. The first part is I'm gonna talk about the basics of Alzheimer's disease. Then I think we'll get 5 to 10 minutes for Q&As. Then we are going to discuss the treatment for Alzheimer's disease. This is my disclosure for this presentation. And this is the agenda that I'm going to cover, hopefully, today. Okay, so the criteria or the naming of dementia changed remarkably after DSM-5. I think this is well known for, oh God, what is this? I think it's not working slide. Okay, it's okay now. So No more, according to DSM-5, no more dementia, no more mild cognitive impairment. Now we are talking about major neurocognitive disorder and mild neurocognitive disorder. When it is major, there is an evidence of cognitive decline and associated even with interfering negatively in everyday activities and even negative impact on independency of the patient. While when it comes to mild neurocognitive disorder, which is representing the old terminology or the more common terminology, which is MCI, there is evidence of some cognitive decline, usually in one domain of the cognition, without any effect on the daily activities of living or independency of the patient. I think this terminology now is more important as the are running studies in the field of Alzheimer's disease now, in fact, get interested in this special probably category of the disease, which is the early stage of Alzheimer's disease, as we will see later on as a continuum, in fact. And mild neurocognitive disorder is the early part or the early presentation of Alzheimer's disease. So what are the areas of cognition? As you know, there are multiple domains of cognition. Cognition is not memory, it is language, it's abstracting, praxis, visuospatial skills, personality, and social behavior. So usually we consider Alzheimer as memory or problem in concentration or memory. It is more than this, as we'll see later on here. So there are differences usually between the normal aging and between dementia. Unfortunately, there is a huge tolerance, at least in this community in Arab area, for the memory difficulties, and it is usually considered as part of normal aging. But we have to recognize some differences between the two, the normal aging and the morbid aging, in fact, or morbid or the early signs of dementia. So forgetting name probably is part of normal aging. Leaving kettle on the oven is sometimes is part of normal aging. Finding the right word, it is like this, while in fact not recognizing your family member, your sons, your grandson, your wife, it is remarkable. It is meaning that the patient is demented truly. If you are substitute, not you don't find wording, but you substitute words with inappropriate words, or even if you are even getting lost in very familiar area for your probably living or residency, it is again a part of or alert us to a pathologic morbidity or dementia process. Dementia has multiple types. We know, of course, about Alzheimer, but again, there are different types and categories of dementia. It depends on the age. Whenever we consider the population below the age of 65 and above the age of 65, there is some differences, as you can see here in this. Do you see my pointer, by the way?
Yes, yes, doctor, it's showing.
You see it, okay?
Yes, yes.
Okay, so as you can see here, when it comes to the population below the age of 65, third of the dementia disease belonging to Alzheimer's disease, while the rest of dementias are different, either related to Huntington, related to Lewy body dementia, alcohol dementia, frontotemporal dementia, vascular dementia, and other type of dementia. Always you have to consider that vascular dementia is existing about 20 to 25% of population. Whenever it comes for population above the age of 65, the vast majority of patients, in fact, up to 60% of them are in fact fulfilling the criteria of the Alzheimer's disease. So Alzheimer's disease is a neurodegenerative disorder, as Maya said in the introduction. It is multifactorial. It is irreversible till now. It is the most common type of dementia, as we saw previously. It is when it comes to the age of more than 65 years, it consisting almost up to 60 to 80% of dementia cases. It is again the leading cause of disability and morbidity in elderly, and it is impacting negatively the public health and, in fact, the expenses related to disability and dependency. There are, of course, multiple proposed theories or to explain the pathogenic event of that is leading to the development of Alzheimer's disease. However, we know now it is related to, it is multifactorial, related to amyloid beta, to tau, to synaptic failure, to neuronal dysfunction, and to gliosis. So we'll see later on more, probably I'll highlight more about this new understanding for the pathogenesis of Alzheimer's disease. This is this showing the current prevalence, previous prevalence and current prevalence of the dementia among a population of more than 60 years of age. And as you can see, in comparison with 2000, between 2009 and between 2009 and 2015, there is remarkable increasing in the prevalence of dementia worldwide. And if you look at the Middle East, here you are North Africa, which is the Arabic probably area, you will find a significant increase in the prevalence of dementia between 2009 and 2015 by at least 30%. And this is, it is usually can be explained by increasing the life expectancy due to multiple factors related to education, to health services, to hygiene. So it's increasing, and it is also behaving same all over the world in different areas, as you can see here. This is again a map showing that the statistics related to 2015, there was at least almost 10 million new cases of dementia in 2015. That means one case every 3 seconds. And again, this, as you can see here, the distribution of, or the number of patients with dementias all over the world. And this is here the scary figure that showing that this number, in fact, is increasing with is supposed to increase remarkably over the coming 2 decades. It's expected that we have almost 130 million worldwide cases of dementia by 2050. In Arab world, there are a remarkable lack of statistical or studies about the prevalence and incidence. I found a few of them from Tunisia, from Egypt, from Saudi Arabia, and from Qatar, I believe, and from Lebanon. This one of the epidemiological studies that was run that did a systemic review for all studies available in this field related to incidence and the prevalence of dementias among Arab population. And they found that the incidence when it comes to age of 50, it's about 2.3%, and it is jumping up to 18% in age group above 80, which is in fact compatible with other countries worldwide. This study was done door to door in, I think, a very rural area in Egypt. And what they found that they looked at the total incidence of dementia, then they look about the differences between male and female incidence, and then according to age group, again, what they found, in fact, is compatible with the international incidence and the prevalence, and again, it shows even increasing incidence of dementia among females, which is again one of the risk factors for getting Alzheimer's disease. So we can divide the risk factors of Alzheimer's disease into 2 categories. One is non-modifiable risk factors, including age, including family history of dementia, including the having the allele of ApoE4 gene, or having the mild cognitive impairment. The modifiable one is related to cardiovascular risk factors. It's including the social and cognitive engagement, including the education, and including the traumatic brain history of traumatic brain injury or traumatic brain injury. So these factors, they are modifiable. The cardiovascular diseases that increase the probability of incidence of Alzheimer's disease include diabetes, hypertension, smoking, and obesity. Lack of social engagement and cognitive engagement also is a precipitating factor of Alzheimer's disease. Again, lack of education or less years of education, again, is a factor that is increasing the probability of the incidence of Alzheimer's disease in the future. Again, age, as we told before, this is a probably one determinant of the risk factors for acquiring or getting the Alzheimer's disease. We'll go for epsilon E4 gene after a little time, and again for MCI. So again, as we said, age is the most important risk factor for Alzheimer's disease. It is, again, as you can see, there is increasing remarkably with age in incidence and the prevalence. As you can see here, whenever the patient are older than 85, probably the prevalence of Alzheimer's disease is about almost 25%. So, but usually we have to understand that Alzheimer's disease dementia is not part of normal aging. It's not even, doesn't have the pathogenic or pathologic findings of Alzheimer's disease. And older age alone is not sufficient to cause Alzheimer or any type of dementia. So dementia, the age is a risk factor, but again, there are other associated factors that contributing to incidence of Alzheimer's disease. This is showing that we know that female also at higher risk of getting Alzheimer's disease. There are multiple explanations. One of them that life expectancy among women are longer than men, and this put them at risk of getting Alzheimer's disease at the age is one of the main risk factors. The other, in fact, contributing factors related to that women, in fact, are at higher risk to getting cardiovascular events after the age of 65 in comparison with men. Additionally, there is some evidence that amyloid beta spreading and deposition in the female is faster and more probably spreading more than in men of same age and same cognitive status. There is also additional factor related to the differences in average of brain weight between male and female. As you know, the average female brain weight is at least 10% less than the matching age of men. Additionally, there is some contributing factors for hormone, the estrogen hormone and estradiol. As you know, this is important for brain plasticity and the neuronal survival. And after menopause, the ladies usually or female lack this hormone, and they are at higher risk of getting a lacking of this neuroprotective agent, and they get probably more probability to get the neuronal injuries due to this lack of this hormone. The genetic predisposing factors, it's very complex. It has multiple factors, including some genetic susceptibility and some that induce some molecular mechanisms. In addition to, of course, that we understand that this is not only genetic disorder, so there is some interaction between gene susceptibility and some environmental factors. Although we know that there are some probably evident that whenever there is one parent or sibling is having a dementia, there is also higher possibility that the other sibling or other part of the family is having dementia or Alzheimer's disease. But again, this is not enough risk factor to put a person at higher probability to getting dementia. We know at least three dominant genes to cause early onset of Alzheimer's disease. The first one is amyloid precursor protein, and presenilin 1 and presenilin 2. And this gene, in fact, are related to amyloid process, which is accelerated this process among patients who are having these genes, and it is responsible for the presentation of early onset Alzheimer's disease, which is in fact typical in clinical presentation at the late onset of Alzheimer's disease, but the age of onset usually is at around 50 or late 40s. Now, when it comes to the allele of epsilon apoprotein epsilon 4, again, it is it is put the patients at higher risk, but again, it is not a guarantee that all patients who are having this allele are gonna to be having the Alzheimer's disease. The modifiable risk factors, I talked already about them. Whenever you have an education, low number of years of education is putting the patient at the risk of having Alzheimer's disease more than other who are having probably more number of years of education. Cardiovascular, again, we talk about hypertension, diabetes, hypercholesteremia, obesity, and acidity. And remember, again, this also risk factors are more correlated with vascular dementia than Alzheimer. Again, there are some evidence that increasing the risk, especially in the midlife age, it is are correlated with more incidence of Alzheimer among this population. Traumatic brain injury due to hyperexcitability injury, again, put the patient at higher risk of getting Alzheimer's disease. There are also evidence about the sleeping disturbances, especially sleep apnea, and some probably sedentary lifestyle, and again, lack of engagement, either social or cognitive engagement. Some studies about some types of diet that are unhealthy type of diet, also putting patient at risk of getting Alzheimer. And anxiety and depression also are recognized risk factor of developing Alzheimer's disease in late ages. I think there's some issues. So we know now that the pathological findings of Alzheimer's disease are preceding the clinical presentation by at least 15 to 20 years. We know that amyloid plaque is, we have evidence that amyloid plaque are existing in the brain of patients with Alzheimer's disease almost 20 years prior to the clinical presentation. When it comes to tau, also it's same, it's almost 10 to 15 years prior to clinical presentation. And this figure showed the different probably symptomatology of the Alzheimer patient when it comes to some reading problems, some short attention, impulsivity, short memories, all this stuff. So prior to this clinical presentation, the pathological finding in the brains of this patient had been started almost 2 decades prior to this clinical presentation. Now, from where we are getting this tau and amyloid beta, let me start by this here. This type of the amyloid, beta amyloid is in fact a protein, a transmembrane protein. The turnover usually in healthy persons, when it comes the turnover of this protein, it goes into amino acid short products of less than 40 amino acids. However, due to some pathological changes, especially in enzymes related to secretase, there is a production of amino acids products of 42 amino acid products, which is insoluble and tend to aggregate and contribute to produce fibrils and amyloid plaques, which are insoluble and deposit in the parenchyma of the brain between the neuronal cells, disrupting the communication between cells and affecting the functionality of the brain. Whenever it comes to the tau is usually the component of microtubules, and which is in fact important, contributing to the neuronal cell integrity. for reason or other, this tau product is going to, it's producing now the turnover. If microtubules go into producing phosphorylated tau, which again, it's a protein that tend to aggregate and consist of neurofibrillary tangles inside the neuronal cells that is again impacting the communication and the transmitter and functionality of the neuron. Subsequently, there will be a negative impact on synapses and in the integrity of the neuronal cell, which lead by the end to the cell apoptosis, cell death, and formation or gliotic changes. So again, same probably presentation. So amyloid consisting of monomers that are consisting of proteins, almost 24, amino acid of 24, at least 24 amino acid that is producing oligomers. This is in fact considered soluble. However, when there is a fibril or amyloid plaques, again, this is insoluble and impacting the parenchyma of the brain and connectivity and networking between the neurons in the brain. This gives some information about that formation of toxic amyloid plaques. In fact, is an important stage in order to produce or induce the production of toxic tau. And the toxic tau is in fact the pathology that is directly inducing the synaptic dysfunction and the neuronal death, and subsequently the clinical manifestation of memory difficulties and impairment of cognition. So pre-existing of amyloid plaque and other related amyloid toxic species are very much necessary and inducing the protein of kinase and phosphatase to produce the phosphorylated tau, which is in fact the main trigger of the clinical presentation of Alzheimer's disease. This is following the same regardless of the Alzheimer's disease, if it's related to a gene or it's inherited type of Alzheimer's disease, or if it's sporadic. Again, the same pathway is going to producing first amyloid oligomers, then amyloid plaques, then in fact inducing inducing kinase and phosphatase the enzyme activities to produce phosphorylated tau and tangle, and then there is widespread synaptic dysfunction and neuronal death, which is ending by the symptoms of pathogenesis of symptoms of Alzheimer's disease and other dementia. The deposition, in fact, of amyloid start with this red area here in cortex, firstly, and initially, and as we said before, it starts almost 20 years prior to the incidence of a clinical manifestation. Subsequently, it goes to orange area, here, especially in the hippocampal area, and here in the mesial temporal areas. And in late stages, there is impact also or effect on the midbrain and bones and even cerebellum. This is the area where in fact, telling us that the coding of memories is spreading all over the brain. So there is no specific area for the memories or cognition, is different areas, although we know that condensing or the first stage of condensing of memories is related to hippocampal areas in the brain and to the mesial temporal areas. The clinical manifestation of Alzheimer's disease, it has a lot of clinical manifestations. Most probably important one is memory difficulties, and it starts with recent memory. So patients start to misplace his objects, start to frequently asking the same questions. Then subsequently, there are different domains are impacted by this process, including executive functions. Calculation is important. The family notices that the patient is not handling his financial issues correctly. Sometimes he give money to somebody, get some money from others without recognizing these events. There is also, as I said, also there is some behavioral and psychotic symptoms, which might include patient becoming more apathetic, more isolated, doesn't want to communicate with relative or friends, and he has some social withdrawal, or sometimes becoming more aggressive and more agitated, so it's difficult to control his behavior. There are other symptoms, of course, related especially to sleeping disturbances. The circadian of sleeping is impacted negatively, and you find that patient is sleeping in the daytime, becoming more agitated and active during the night. Occasionally, there are seizures and some focal neurological deficit. So it depends. Every case is different from the others. It is very important when it comes to first presentation to recognize or confirm the type of dementia. So usually the Alzheimer disease is amnesic type of behavior. So patients starting with amnesia, while frontal temporal lobe dementia is behavioral changes start as early, and patient becoming apathetic or having some behavioral or language difficulties. Vascular dementia, this is very, in fact, having different presentations. So it sometimes might relate to motor vocality, language difficulties, behavioral changes, or sometimes amnesia. Dementia with Lewy body, it is dominant usually by visual hallucinations and sleeping disturbances. Again, there are other parameters. This is for specialists and for specialist clinic, but usually for the first presentation to GPs or other family practitioners or general internal medicine, the categorization should based on the initial presentation. If it's amnesic or non-amnesic, there is some behavioral or some or psychotic presentation at the beginning. Then following this, we can go to other bars to confirm the diagnosis of this type of dementia. Again, as we said in the first slide, after you establish the clinical and cognitive, after establishing the dementia syndrome, we have to categorize if this is related to MCI, mild cognitive impairment, or it is only, or it's a mild dementia, or it's full-blown dementia. Again, as I said before, the MCI doesn't impact the daily activities of living of the patient or their independency. This is usually impacting one domain mainly, while in dementia, due to the Alzheimer disease, there are multiple domains are impacted, and the patient again is lacking his independency, and there are remarkable interaction or interference with his functional capacity to work and to communicate with others. Of course, as we said again, we have to recognize the type of dementia, and always we have to think about reversible causes of cognitive impairment that mimicking the dementia or Alzheimer disease. On top of them, in fact, depression, thyroid dysfunction, vitamin B12 deficiency, folate deficiency, normal pressure hydrocephalus, and obstructive sleep apnea. This always should be ruled out prior to confirming the diagnosis of Alzheimer's disease. Again, there's some differences between the normal aging, MCI, and Alzheimer's disease, dementia, and it goes through different domains of cognitions. But again, it is the extent and the impact on daily activities of living is the most determinant factor in differentiating between at least the normal aging and MCI and Alzheimer and other parts. After clinical presentation, we go to some clinical assessment, bedside clinical assessment. Usually in our clinic, we use mini mental stat examination, which is very handy and takes few minutes. Some people or some expert prefers to go to Montreal cognitive assessment. We are not using this, at least in our clinics, but the mini mental status exam is very easy and very handy and can be performed within 3 to 5 minutes. And again, it is reliable. Hardly we refer any patient for neuropsychological testing, although it is important for many reasons. It is important, especially if you have to baseline the patient in order to follow closely the patient over time. It is also to differentiate if this is Alzheimer or any other type of dementias. And it is also important that for some legal or guardian issue when it is required, especially by the court. Again, it is important sometimes to go for compensatory or some but when we are putting strategies for compensatory and rehabilitation or any other treatment. So it is important in some occasion to send the patient for a neuropsych assessment, especially at the early stages of dementia or MCI. Neuroimaging, we have different modalities of neuroimaging. The MRI is probably the standard or golden standard for establishing or the structural brain pathology to confirm if there is any lack or decrease in volume, especially in the temporal area here in hippocampal volume loss. Again, the most important even need or indication for structural imaging studies, MRI or brain CT, to exclude other pathologies, especially if there is any intracranial masses or hemorrhages, or as we see again later on as when it comes to following some types of medication and new types of the treatment. So usually it is indicated at least for exclusion of other pathologies. Again, it has some confirmatory findings of dementia when it comes to finding of hippocampal volume loss or mesial temporal areas loss. PET scan and SPECT are hardly used, although it shows the areas of hypometabolism. As you know, that the gliosis usually considers as a dead area and there is no signal of metabolism. So when we send for patient for PET scan, in some occasion, very rare occasion, we find areas of, especially in the hippocampal area and mesial parietal lobes, showing remarkable hypometabolism signals. As you can see, this is the normal, where the red spot or the hot spot showed the activity or hypermetabolism or regular metabolism activities. When it comes to advanced dementia, as you can see here, or the yellow or green, and that mean that this area is in fact more to be gliotic area than active neuronal areas. Amyloid PET scan imaging, this is for research currently, but it is now necessary, especially with the availability of the new modality of disease-modifying therapy, and we have multiple types of a tracer. It is currently not very much available. So, but again, it is important to confirm the diagnosis. If we don't have other biomarkers to replace this imaging type of confirming of the diagnosis. So either we go for PET scan for amyloid, or we can go to CSF, as we'll see later on. But currently, again, it is regulated, especially in states and Western areas, only for, I think, research. Same for tau PET scan. Again, it is tracing the disease progression, and it is necessary to confirm the diagnosis of Alzheimer's disease. But again, it is not handy; it's not available everywhere. So we usually replace them by either getting amyloid beta 42 or amyloid 42 over 40 in CSF. Again, or we go for tau. Again, in the CSF, we get total tau and phosphorylated tau instead of PET scan for tau. Again, as we said before, initially structural MRI is important, and sometimes we go for PET scan, BDGF, for looking for the metabolism signals in the brain. Now, biomarkers, how these biomarkers in fact are working together, how we follow them. As I said, the disease of Alzheimer is a continuum, start from preclinical stage to MCI to dementia. We know that pathology is existing now almost 20 years prior to the clinical presentation. So initially, there is with time, there is there is some signal about abnormality in amyloid beta and CSF and amyloid imaging. If we have even the access to amyloid PET scan, so we can find some evidence about pathogenesis, pathologic findings in patient at higher risk to get the disease of Alzheimer at the preclinical stage, almost 20 years prior to the incidence of the clinical incidence of Alzheimer's disease. Subsequently, as you can see here, we start getting some abnormal signal, especially at MCI when it comes to PET scan, FDG. This is related to metabolism. If we look also for hippocampal volume, start noticing decreasing in the volume or shrinking in the volume of the hippocampal area, and start getting some evidence about increasing concentration of tau in CSF. Now, their last probably stage here when it comes to dementia was the last onset here, and you can see that start the clinical presentation at the very late stage here. In dementia type, you start to notice the impact on activities of daily living and impact on cognitive performance. So cognitive performance and the clinical presentation is very late in the process or of pathogenesis of Alzheimer's disease. It is preceded usually by evidence of amyloid deposition in the brain and subsequent even PET positive tau findings in CSF or PET tau, while the clinical manifestation is very much late in the process of the disease. This gives you the summary. We do MRI to get the exploring of the regional anatomy of the brain, so we can find the hippocampal volume loss and temporal and parietal atrophies, and then global brain atrophy. Remember, this is very late. It is not an early signs. It's hardly to appreciate these findings in early stages of the disease. It is usually late. And this the shrinking in the volumes is a sign or a presentation of a neurodegeneration of the brain. Amyloid beta 42 in the CSF is decreasing in concentration as a marker for brain amyloidosis. When it comes to tau also, again, there is increase in the concentration, and again, this is a marker for neurodegeneration in addition to aggregation of the tau. If we go to the PET scan, you will find even according to the either a increased uptake of amyloid and tau when it comes to metabolism, hypometabolism. According to the DSM-5, this is the criteria for diagnosis of Alzheimer's disease. Again, there's supposed to be an evidence in decline in some of the cognition domains, including learning, memory, language, executive functions, social cognition, with other even factors that are needed. And usually we have, especially nowadays, we are having disease modifying therapy. We have to confirm the diagnosis correctly, and we have to follow strictly the criteria either for DSM-5 or any other criteria like National Institute of Aging and Alzheimer Association. It is different a little bit, but again, by the end, it is same conclusion. So what about MCI due to Alzheimer's disease? It is usually patients are amnestic, giving some amnesia. It is mild, with mild cognitive impairment. It is not impacting the daily activities of living. It is not impacting the social functionality of the patient. It is Probably the early stage of Alzheimer's disease, as we know from many observational studies, that at least 10 to 15% of these category of patients are converting into Alzheimer's disease every year. But what they found now with the availability of biomarkers, that whenever we have some evidence about amyloid or tau, if there is any amyloid or tau deposition, we have that the conversion from MCI to Alzheimer's disease is almost 60%. However, when we have MCI with lacking of this evidence of amyloid and tau deposition, the conversion is less than 12% every 3 years. If this is positive, we have some positive, it is 60. So it is important, in fact, to recognize this category and again to find if there is associated evidence of amyloid and tau deposition. This is very high. Then it is high risk category that this type of patient with positive biomarkers are converting into a full-blown Alzheimer's disease, almost 60% over 3 years. As I said before, Alzheimer's disease is a continuum. It starts from preclinical, MCI, mild cognitive impairment, then moderate dementia and severe dementia. See here, it's normal aging is separated from this continuum. It's not part of this continuum. When we, from a preclinical to severe, we have some evidence of Alzheimer's disease pathology. If we have the way to, or if we have the mean to get any study related to tau or related to amyloid, we'll find some evidence about amyloid and tau deposition in the brain. Cognitive impairment start lately and the disease. It is at least start in the early stage of mild cognitive impairment. Functional decline, in fact, start with dementia, early stages of dementia. And then in moderate and severe of cases of Alzheimer's disease, the behavioral and psychotic features are dominant, the clinical pictures. And same here, but I have just to differentiate between the preclinical feature that the patients, in fact, are having the pathology, but yet individuals are by definition here asymptomatic and cognitive normal. So it is an very early stage of the disease. So when we are talking about a preclinical Alzheimer, if you remember here, preclinical, this is a preclinical stage. Now, when we are talking about the pre-symptomatic, the patient referred, they are cognitively normal and they are asymptomatic, but they are having dominant inherited gene mutation that cause Alzheimer's disease. They are pre-symptomatic, but they are definitely going to be having Alzheimer's disease. Here, the ATN biomarker profiling of the patient, again, amyloid, tau, and the neuroimaging. And if you see the Alzheimer continuum is when we are having amyloid is mandate, supposed to be in on all probably stages of the disease. Amyloid is positive. Occasionally, in somebody we lack tau, and there is no evidence, especially in a very early stages. We have amyloid evidence of deposition, as saw in previous slides, but tau is still negative, and the neuroimaging doesn't show any lack in the volume of hippocampal area or temporal mesial area. So this is in early stages. Subsequently, when you have tau positive, neuro again imaging is negative. This is Alzheimer's disease. When all these three positive is Alzheimer's disease. Again, when here there is some cases when Alzheimer you have amyloid, negative tau, and positive neuroimaging. Again, there is you have to suspect here that probably Alzheimer's disease with other pathology. Here, the password, the journey, I think this slide is not going well. I don't know why. This slide, okay, let me see why the problem. This is a stage of diagnosis starting from history taking, from family history, from a neurologic clinical examination, then bedside cognitive assessment, and neuropsych assessment. Subsequently, go to structural imaging, which is MRI. Then we go to biomarker. Biomarker, including tau and amyloid in CSF, or getting some imaging is availability, then come for securing the diagnosis in order to start the treatment of the patient. The
So Dr.
prognosis.
Shahra, excuse me for the interruption. Do you want to continue about prognosis, or do you want to take some questions and then?
I think this is my last slide.
Okay, sure.
So the prognosis of the disease is variable, and usually this is within 3 to 10 years, sometimes more, according to the health services available in different areas of the world. Patients with early onset Alzheimer, in fact, are usually having more aggressive and rapid course of the disease than the late onset. And remember that the early onset is usually genetics. The primary cause of the death is usually related to intercurrent disease, such as pneumonia, cardiovascular, DVT, and other diseases. I think this is the end of my first presentation. So probably, yes, we can go for questions if we have time. And I have to drink some water.
Yeah, sure. So thank you, Professor Shahra, for a very informative presentation about the etiology, the pathophysiology, the risk factor, and the diagnosis of Alzheimer's disease. So we will take some questions, but please limit your question to this topic, as Professor Shahra will go in details into the management of Alzheimer's disease, and he will tackle treatment in his next presentation. So limit your questions to the first topics discussed. So let us take the first question. So if the prolonged use of antihistamine could be a trigger for dementia?
There are some use of some medications that are associated with increasing risk of Alzheimer or any other dementias. But again, the evidence, the clinical, this is observations, and the evidence about this is in fact small. It's not, it cannot be said that this medication is gonna to put this patient on risk of dementia. We know about tricyclic antidepressant medication, prolonged use, causing some memory difficulties, sometimes antihistamine, some other medications. But from a scientific point of view, we cannot say that antihistamine is a risk factor for developing dementia.
And talking about factor, are there any environmental factor that could cause Alzheimer other than the genetic predisposition?
Yeah, of course. When we are talking about socioeconomic status of the patient, sometimes, yeah, it is a cause. And we have good evidence in the prevalence and incidence that socioeconomic class of the patient, especially low socioeconomic class, is a risk factor. We have good evidence from states. It is a risk factors, even among some, but other risk factors mean that some environmental, I don't know, but this is a low socioeconomic class, in fact, is putting patient at risk for developing dementia. And again, this is usually related to many other issues, because this group of patients or people, they don't get good education, which is again a protective factor against dementia. So it is complex, but again, yes, lack of or low social economic class is, especially this one, is putting patients at higher risk of developing Alzheimer.
So more question about risk factors. It seems our audience are concerned how we can prevent this disease. So is low IQ a level or a risk factor, low IQ level, a risk for dementia?
Low IQ, I can give example about developing dementia, especially or among like trisomy 21 or Down syndrome. A patient even here having low IQ, especially 70 to 80, they are usually at higher risk of developing Alzheimer's disease. Again, this is complex and it is not an easy, because as you see even that some also genetics related to Alzheimer's disease are more presented in some chromosomes, which is 21, which is trisomy 21 of Down syndrome. Low IQ itself, this is an example in Down syndrome. Yeah, it is Down syndrome, at least it is a risk factor of developing Alzheimer.
If there is any relation with GLP-1 deficiency and Alzheimer's disease, especially, or if there is a relation between obesity and Alzheimer's disease?
There are multiple observational and epidemiological studies that linked obesity to Alzheimer's disease. And I did not go through all of them because of lack of the time, and I have to be more concentrated. Obesity itself, yeah, it is associated with increased risk of Alzheimer's disease, and it is also a risk factor for vascular dementia. Yes, all cardiovascular risk factors are contributing to Alzheimer's disease and are contributing at the same time to vascular dementia.
If there is any role for heavy metal toxicity, like aluminum toxicity, in the development of Alzheimer's disease?
There's a lot of some cases about such a thing, but I'm not sure if this is confirmed from scientific point of view as a predisposing factor for Alzheimer's disease. But if you go through the literature, we find some studies about putting this patient at higher risk for developing multiple types of the neuropsychiatric diseases. So it is existing, but it is not recognized as a cause of as a risk factor of Alzheimer's disease.
Another question, do you recommend any cognitive activity that would prevent or delay the development of dementia in normal persons?
Usually we are advising that always for cognitive engagement, always. We ask our patient to protect themselves by learning. Every stage of their age, they have to learn some cognitive probably, or for some cognitive exercises. Now with existing of many probably devices, they can follow even any task, cognitive task on the mobiles and on any even the regular teaching or education task. So we recommend usually to keep the brain engaged in activities, in new activities, in a new task always. But again, this is now more handy with availability of the devices and handy devices like mobile or computers or whatever. So learning is easy and simple and accessible, and keeping the brain all the time engaged in the new activities and the new probably learning is protecting against dementia.
Another question, any association between vitamin D deficiency and Alzheimer's disease?
You will find something like this. Vitamin D is associated with everything.
Yeah, with everything.
So, I don't like to answer this question. When it comes to vitamin D, you can find evidence that link vitamin D for cognition, for heart diseases, for skin disease, for eye vision, for any disease. So you can find, but nothing like recognized again scientific way, robust evidence that this is a risk factor.
And have you observed Alzheimer's disease during your years of practice in early age, such as 30s or 40s?
Yeah, we recognize some familial types of, and we have some confirmatory even evidence from genetics. This is very rare. You can probably, as if you are practicing in neurology in like tertiary hospital, or you can find such referrals probably every 5 or 6 years. But again, it is easy to recognize them because there is some family history of Alzheimer early stages. It's very uncommon, but it is existing. And if you practice in well-referred center, you will get some cases like this.
Another question, if there is any relationship between skull-based trauma or skull-based fracture and the occurrence of Alzheimer's disease?
Yeah, traumatic brain injury is well recognized cause of our risk factor for Alzheimer's disease. And this is related to hyperexcitatory injury that ended by neuronal massive neuronal deaths. So subsequently, patients are developing, in fact, dementia syndrome, and part of them is getting the clinical and biomarker probably picture of Alzheimer's disease.
And what are the early signs that are alarming for a patient so he can go and consult a physician? The early alarming sign.
Usually we consider Alzheimer's disease as amnesic disease or amnesic dementia. So patients start to forgetting. Again, forgetting things sometimes if you start getting some like misplacing your objects or some belongings to you, or making some mistakes in calculations, or recalling the names of very close family relatives of or friends. This is, I think, the early sign. This is an amnesic disease. Amnesia is or forgetfulness. It's the early sign. Now, in the early stages, you cannot probably differentiate between, as we said before, that normal aging is also associated with some forgetting things. But again, it is when you get this forgetting is more frequent and start impacting your life, start impacting your communication with in the society, with the family, with a friend. I think this is an early sign. At this point, it's just better to seek the medical attention. Always the early stage of the disease is my cognitive impairment. So there's some amnesia, but again, it's not impacting the activities of daily living or the communication or the independency of the patient. Still, I'm having a patient who having mild cognitive impairment and drive by himself from Dubai to my clinic in Abu Dhabi. So, but still he is amnesic and he has some issues in amnesia and recalling names, and even some bad probably performance in calculations.
I have two questions related to epilepsy and Alzheimer's disease. So does status epilepticus affect or cause or induce dementia or Alzheimer's disease? And does the use of anticonvulsants, especially long-term use of sodium valproate, can also trigger Alzheimer's disease?
Now, the correlation between Alzheimer or dementia and anti-epileptic medication, it is a complex little bit and bidirectional. So Alzheimer disease might present it for first time as a seizure occasionally, but the status epilepticus itself can be presentation. Yani presentation of seizure can be presented either an isolated seizure or probably status epilepticus. So presentation, but usually status epilepticus is very short lived pathology. So it is not like nobody is living his life when status epilepticus. So it put him at higher risk of getting Alzheimer. So no, but seizure can be an early manifestation of Alzheimer's disease. And the other issues about the valproic acid, it has long-term neuropsychiatric or neuropsychologic even changes on the patient. So it making them slow, it making them sometimes having some difficulties on concentration and memory. But as at the long term, putting the patient on higher risk of getting Alzheimer, I think I cannot say about this. I did not read about it. I have to go back and find if there is any evidence or recognized probably good cohort studies or good evidence that valproic acid itself can cause this. But I know for long term, I am following patients who had been using this medication for more than 20 years, either for bipolar disorder or for epilepsy. And I know they have some like Parkinsonian type of Parkinsonism, some slowness in reactions, but they are not amnesic or demented. So I'm following some patients like this, but they are not demented. I have to go back and find an answer if there is any evidence from any good clinical data about this. But from my personal experience, I don't think there is any evidence. There's some neuropsychological changes related to long term, but not as dementia or Alzheimer.
Another question, if one have a strong family history for Alzheimer's disease, but he or she's asymptomatic, how can we prevent the disease?
It is here, the question is a little bit, again, difficult. If there is a good family history of incidence of dementia among elderly in family, it is related, it is putting the patient at slight higher risk of getting dementia than other populations. If it's an early onset dementia below the age of 50 or Alzheimer below the age, then it is better to seek again genetic studies or follow this closely, because early onset Alzheimer disease is usually genetic, and there is a dominant gene in this in the pathogenesis of this disorder. Late onset, strong family the history of late onset Alzheimer disease is slightly increasing the risk of developing Alzheimer among relatives or close or first degree relatives. Again, the protection is related to engagement, is cognitive engagement, physical engagement, following healthy lifestyle, social activities, keep the risk factors or treat the risk factors that are available, especially when it comes to obesity, hypertension, cholesterol, and sugar, blood sugar. So all this controlling, all of this is protecting against developing Alzheimer in sporadic conditions.
Since we are talking about condition that may lead to Alzheimer's disease or predispose more to Alzheimer's disease, we have one question related to stress. So does the stress or a stressful lifestyle induce Alzheimer's disease?
I believe, yes, we have very good evidence. I put it in the risk factors. History of anxiety and depression, in fact, is putting the patient at higher risk for developing Alzheimer's disease.
And what about the peak age for Alzheimer's disease?
Usually, peak age, it's the incidence usually around 60s and 60, 65. This is for sporadic cases. For genetic cases, is below 50.
I will take two more questions and before we move to the treatment session. So is the long-term use of antipsychotic medication, mainly benzodiazepine, lead to Alzheimer's disease?
There are many publications about this, that benzo, yes, increasing the risk of
dementia.
dementia. Yeah.
And if a patient has memory impairment with one personality change, can this considered a diagnosis as we have a diagnosis of Alzheimer's disease?
I think no. Again, there are criteria, strict criteria. Now we are following them closely in order to confirm, as we are having now disease modifying therapy. So we have to go through all these criteria, in fact, to confirm the diagnosis. It's not only like having memory. Again, you have a big exclusion list. I mentioned and highlighted the bar that in every prior to confirming the diagnosis, there we have a treatable mimics for Alzheimer's disease. We have to exclude all of them, this including vitamin B12, thyroid dysfunction, depression, normal pressure, hydroxyl. All this stuff should be, in fact, or all this disease should be excluded initially prior to confirming the diagnosis, and we have to follow the criteria, either DSM-5 or probably the National Institute of Aging and Alzheimer Association.
Final question, I'm not sure if you can answer because it needs more an immunologist or a lab researcher. So how do we induce Alzheimer's disease in the mice model in the lab to test all these medications?
I'm not sure, no.
Okay.
Yeah. It needs,
Thank you.
it needs scientists in this field.
Yeah, it needs an immunologist, so it's not our specialty. So let's move to the treatment session, where Professor Shahra will discuss the novel therapies as well as the all the treatments for or the conventional treatment for Alzheimer's disease. The floor is yours, Professor Shahra.
Thank you, Maya, again, and I will go through the treatment. In fact, I'm gonna to go briefly because my understanding that the medication is not approved in many countries, so it is probably it's not good to talk about a medication that not licensed or approved in many regions of the world. So again, we have to understand that till this moment there is no cure available for the disease. So all the medication that we are having now, either symptomatic treatment, and we have now a new treatment, as mentioned at the introduction by Maya. In June 2021, we received the approval for the first disease-modifying therapy, which has shown some effect in slowing the progression of the disease. So the first group of medication that we use to treat patients symptomatically, at least, it is the cholinesterase inhibitors. We have three of them now available commercially for the past 2 decades. It's include donepezil, rivastigmine, and galantamine. It is increasing the cholinergic transmission. It is enhancing the communication between the cell. As you know, the cells, it is communicating with each other by acetylcholine. So this products, in fact, preventing the degradation of the transmitter between the cells and increase the bioavailability next to the synapses. So patient with a newly diagnosed, usually Alzheimer's disease, they offer this treatment, and it is usually symptomatic, and it shows some benefit and some improvement, especially when it comes to memory and some behavioral changes. Usually, this is a trial which is indicated in early stage when it comes to mild to moderate Alzheimer's disease. When we are talking about mild or moderate, we are talking about mini mental status more than 20 or more than 15. So it's not like advanced disease. This is a Cochrane review for the available trials related to this medication, and it showed that the evidence, it is shown that it is effective and it deserves to be used in the early stages of the disease, although it has some adverse event, but again, it is usually well tolerated and accepted. The other medication is memantine. Again, it is N-methyl D-aspartate NAMDA receptor antagonist. It is a neuroprotective, so you know it is protecting against excitatory transmitters that ending or affecting the survival of neuronal cells. So again, it is also good to be used in mild, moderate, and even severe cases of dementia. It is good as its adverse event is minimal and hardly to appreciate any adverse event when patient is using this one. Again, this is another review which looks at all the treatment, including memantine, and the result had found that there is statistically significant. Also, it is marginal when it comes to improvement in cognition and other manifestation of dementia. This is here the doses that are used and what is the current approval. As you can see, for donepezil, it is approved for mild to moderate to severe. When it comes to rivastigmine, again the same. When galantamine, only mild to moderate to severe memantine. Here doses, and here the formulas that are available, either the oral or patches. And again, how to increase the doses according to different intervals. So for memantine, we can increase the dose within 1 week as 5 mg, while for the other, usually the cholinesterase inhibitor, it requires at least 1 month to change the doses. Till to 2021, the first time when the FDA gave the approval of aducanumab as a disease-modifying treatment, and at that time it was a breakthrough news. And you can see now it is on the cover of the Nature and many other magazines. So it was truly a breakthrough. Since 2003, this was no treatment. So over 2 decades, no treatment approved by any authority in order to give some either symptomatic or any type of treatment for this disease. Aducanumab is a monoclonal antibody. It's directed against amyloid beta. It was approved now for the treatment of mild Alzheimer's disease. by using now accelerated approval pathway based on some positive and some group of the pivotal studies. We have two trials in the pivotal study, phase 3. A subgroup analysis of one of them had shown positive findings or fulfilling all the endpoints. So based on this, get the accelerated approval. And now there is a trial, even to further trial is required to verify and validate the clinical benefit over the coming years. So it is usually it is reducing the amyloid beta plaques in the brain. And I think if you go back here, this picture from the PRIME study, which was a 1B study, phase 1B. And as you can see with the using of the higher dose, which is 10 mg, there is complete clearance of amyloid in the brain. I'm sorry. So what aducanumab is doing, in fact, it is binding to the N terminals of the amyloid beta, and this is releasing or reducing the deposition inside the brain of these plaques, and enhancing by the end the communication between the neuronal cells, and enhancing the communication between synapses. It is a human IgG1 anti-amyloid beta monoclonal antibodies. Again, it is in fact targeting the soluble. As we know, there are soluble here, the monomers, and on insoluble, which is fibrils and amyloid plaques. So it is binding to all of them and reducing the deposition and enhancing the clearance from the brain. Initially, based on the good evidence came from the PRIME trial. Again, the PRIME trial has shown good clearance of amyloid from the brain, and again, either improvement in the cognition and the slowing in the progression of the disease. Based on this, they went into the phase 3 trial, as we will see later on. So how to select patient to go for this treatment should be this is, in fact, selection can be good. Again, the approval came as accelerated approval, with based on subgroup analysis of part of one of the two pivotal studies. So because of this, a lot of concern, there was strict selection of the patient to go to this type of medication. Okay, so the based on this, aducanumab should be only considered for some selected patients. The selection should include either MCI, should be MCI of Alzheimer's disease, not for MCI for Lewy body dementia, not for vascular dementia, not for MCI early stage mild cognitive related to Alzheimer's disease. That means there is an evidence, biomarker evidence of deposition of amyloid or tau in the brain, either in CSF or by imaging. The other category that might include in the selection of the patient, mild Alzheimer's disease. That means many mental status exam, state exam is score is less is more than 21. So it is mild disease. It's not like 15 or 10. Again, we have to get documented amyloid pathology either by CSF or by imaging studies. We have to get no contraindication for using aducanumab. Patient should not be offered aducanumab if they are at higher risk or at high risk for hemorrhagic side effect. And this is, you will see later on, to some adverse event related to this category of medications that we know about this since 2009. So we know that all these medications that are clearing amyloid from the brain are associated with some type of complications. We can diagnose radiologically. We'll see later on. So one of them is hemorrhages, small hemorrhages or micro hemorrhages, micro bleed in the brain. So because of this, any patient at higher risk of getting this hemorrhage should be ruled out, not be excluded. ApoE also, we have to again to check the status of the patient prior to initiating the treatment. Patient must also be able to adhere, as this is infusion, and it needs visiting monthly, and it needs also following safety and monitoring guidelines. by at least by MRI and other follow-up procedures. The infusion, it comes initially first. The first infusion is the dose is increasing with every infusion. It's starting the first and second infusion 1 mg per kilogram over 1 hour. Third and fourth 3 mg over 1 hour. Fifth and sixth infusion, again this is infusion, monthly infusion or every 4 weeks infusion. Now then after that the maintenance goes for 10 mg per kilogram over 1 hour. We have some studies for up to I think 70 or 80 infusions. So this is what is in the leaflet of the medication. The brand name is at home, and this is from the FDA approval. As you can see, the most common adverse event that happen in at least on 2% of the patient is ARIA AE. We'll see later on about ARIA. It happens like, as you can see in the active medication in 35%, headache in 21%, area hemorrhage, microhemorrhage, or cirrhosis. Again, it's happened almost 20%. Some frequent falls, diarrhea reported in a few number of the patient, and some patients also suffered from altered mental status or disorientation. Most of these adverse events were short-lived and mild. Okay, so we'll talk later on about ARIAs because this is probably the most important adverse reaction to this type of medications, not only aducanumab and all the series that are working in similar way by other industries and will show very soon in the market. So amyloid, the ARIA is amyloid-related imaging abnormalities, okay? So ARIA was reported in approximately 40% of patients treated with the highest dose. Remember that 1, 3, and 6, and then we go to 10. So when we go to 10, there are at least 40% of the patient cases complicated by ARIA. This is again amyloid related. It is imaging, okay, abnormalities. Okay, so the risk increased with the existing of ApoE epsilon 4 alleles. Because of this, it is a requirement prior to start treatment to know the status of the patient about having this allele. Again, ARIA can occur at any time during the treatment, and it is either ARIA E stands for edema, or ARIA H as stand for microhemorrhage or hemosiderosis. Here examples, this is area E. Area E, as you can see this here, it is an edema, area of edema, while here you can see microbleed or microhemorrhage. Here is again edema, and here also edema. So it is two types, edema or microhemorrhages. It is usually associated with mild symptoms. Again, there should be close monitoring. And during the study, there was a close monitoring by MRI and by clinical assessment. Why ARIA it happens? It happens because especially the amyloid, because due to the amyloid clearance in the brain, that what they found that patient with Alzheimer's disease, they have amyloid plaques inside the brain, and they have also amyloid deposition in the smooth muscles of the vascular and the vessels inside the brain. And whenever the medication is starting to be active, there will be also some associated clearance of these plaques inside the wall or on the layer of smooth muscle and the vascular system inside the brain that induce leak because of this clearance of this amyloid plaques. So due to this issue, there will be either microhemorrhage or edema, vasogenic edema. So it is due to the clearance of amyloid, either from the brain itself or from the wall of the vascular system inside the brain, due to the existing of amyloid in the walls of the arteries. There are categorization, and according to radiological severity. It is radiological severity again. So if when it comes to edema, it related to the size of edema. If it's less than 5 centimeters, it's mild. It is less than 10 centimeters, it is moderate. It's more than 10 centimeters, it is severe. When it comes to micro hemorrhages, if the number is less than 4, it is mild. Between 5 and 9, it is moderate. With more than 10, it is considered severe area H. Also, sometimes they count for siderosis area, superficial siderosis. Again, according to the focal area, either 1 or 2 or more than 2, according to the severity. Now, how we are monitoring this patient who are receiving aducanumab, we either clinically by looking for a headache, confusion, focal neurological deficit or sign, or visual disturbances. This is main probably symptoms related either to edema or hemorrhages. So always we have to ask the patient about this condition. If there is any headache or confusion, we have to order MRI, or even focal neurological deficit. It is essential to order MRI immediately. MRI monitoring, the standard of MRI monitoring is prior to initiating aducanumab, then prior to the 5th infusion, that is 6 mg, 7 infusion, 12 and 12 doses, to assess the possible adverse event. So it is regular after that to be used in order to look the radiological abnormalities. What about the efficacy of aducanumab? As we know from the clinical trials and some other evidences come post-hoc practice, we know that there is some robust effect have shown consistently demonstrating related amyloid brain depositions level. And as I showed you the picture that on the Nature magazine, there is from evidence from the PRIME study and subsequent other pivotal phase 3 study, there is good evidence that there is good removal of amyloid. But when it comes to the clinical improvement in cognition, they have different in fact findings. It is usually small because the group was had shown the efficacy was a small group. Some people consider it is inconsistent, but I think it is deserved to be followed as we know now from the approval that and the post phase 4 trial that is going on, in fact, to confirm this improvement after using this aducanumab. This is the development clinical maps of the aducanumab started in 2011, and this is probably the most important part when the PRIME trial had shown for the first time that there is a removal, good evidence about removal of plaques from the brain. Additionally, there is good improvement in the clinical endpoints when it comes to slowing down the disease progression. Subsequently, there was ENGAGE and the EMERGE trial, two identical trials that were halted following futility analysis in March 2019. However, there was subsequent analysis for subgroup that used the higher dose of the aducanumab, and they found that in one of these trials that they found that it fulfilled all the endpoint of the study. We'll see this later on. And currently, there are now other running studies. Either this is long, this is the open label extension, and we have the EMBARK and EVOLVE trials. So a few words about EMERGE and ENGAGE, which were the pivotal phase 3 trials to follow or to confirm the findings from the PRIME trial. Both of them were identical studies, multi-center international studies, phase 3 studies, double-blind, placebo-controlled, randomized. They included, as you can see, huge number of patients in 20 countries over the world, 300, almost 50 centers, included again the early Alzheimer disease or MCI due to Alzheimer or mild dementia. So the many mental state exam was between 24 and 30. They used also clinical dementia rating, also 0.5. I'm not very much familiar with this scales, And other scale, the patient should have a confirmed pathology related to amyloid beta. If on acetylcholine receptors inhibitor and it is a stable dose, they were included. Two dosing regime, low and high. The randomization was low, placebo, low and high. Monthly infusion, and the titration was over 6 months. And the primary endpoint was the change on the CDR-SB, that clinical dementia rating, sum of boxes. This is the scale that they use for primary endpoint. They looked at the change of 18 months, and there was another even bunch of other secondary and exploratory secondary endpoints. This is the demographic between the engage and the emerge. Again, this is very identical phase 3 trial. This is you can find that there is no bias when it comes to the distribution among the groups. When it comes to the age, when it comes to the clinical stage of the disease, it's almost identical and similarly distributed among all these groups. When it is a medication even used here before, again, you find the same percentage of patients are using the previous using any medication. Baseline characteristic here, again, when it comes to MMSE, and as you can see, it is almost around 26. That is this moderate disease. And it is mild disease, it's not moderate. So again, when it comes to, so this is if this is more than, again, mild cognitive impairment or mild Alzheimer's disease, this was excluded. So the mini mental status exam score was 26, the average or the mean. And here, as you can see, this is from emergent trial, the clinical endpoint at week 78, the high dose aducanumab met all the endpoint, the primary and secondary, when it comes to assessing the cognition and functionality and behavior of the patient. This is the primary endpoint, the clinical dementia rate is sum of boxes. And as you can see, there is a significant slowing of the disease or improvement in the disease when it comes to this primary endpoint. Same when it comes to other secondary endpoint. And even for tertiary, all these primary and secondary endpoint were fulfilled among this subgroup patients who were at high dose of aducanumab in the emergent studies at week 78. So they fall. And based on this, in fact, although when it comes to the engaged trial, which is went the same way, but the findings were not consistent with the previous, and there was no difference between the placebo and the aducanumab. But based on this, the disease got the approval as accelerated approval with the recommendation for phase 4 study in order to confirm these findings. So the approval based on this subgroup analysis of the patient, and this was in fact initiating a lot of controversy when it comes to the neuroscience communities. Some patients, some expert approve, some expert disapprove. But again, I think this is a breakthrough and deserve to be followed closely. And this is a medication that people or human history were in fact waiting for decades now to get medication that have good evidence in slowing the disease progression and clearing the pathogenesis or pathologies from the brain. Again, now I think there are multiple products under process now and following aducanumab in the field of Alzheimer's disease and other field. And this is the landscape of current research in this field. And this is very promising, I think, area now of the investigation or research. So by the end, this is my conclusion. In fact, I did not want to go through all these complex presentations or studies related to this trial. I just want to give some hints about the findings of this study. So my conclusion is Alzheimer's disease is a chronic neurodegenerative disease characterized by progressive loss of cognition and behavioral capacity. It is common and very expensive, in fact, to get direct and indirect care for Alzheimer's disease. Symptomatic treatment, as we saw, gives some mild improvement or a clinical benefit, and deserve to be used at least in the mild and moderate form of the disease. Now, several agents under studies are potentially disease modifying and may significantly alter the deterioration of Alzheimer's disease. And aducanumab, I think, is the first one on this new category of the treatment of this disease. I think this is the last slide. Yeah.
So thank you so much, Professor Shara, for a very enriching presentation.
I just want to give this slide just how we are reducing the risk. So as we said in one of the or many of the questions, you have to keep your brain engaged, okay, mentally, physically, and socially. You have to follow a healthy lifestyle and you have to take care about your heart, okay? So vast cardiac risk factors are in fact important risk factor of developing Alzheimer. Thank you very much. I think this is my last slide.
So thank you very much, Professor Shara, for a very enriching and actually comprehensive presentation during which you discussed Alzheimer in all its aspects. And please allow me again to take some questions. I know you are tired, you spoke for around more than 1 hour, but you need to profit from your presence with us and your expertise to take some questions. So the first question, which medication is preferred for sleep disturbance and agitation in patients with Alzheimer's disease?
Okay, I think usually we start with medication like cholinesterase inhibitor. It has good effect on some behavioral changes. And usually we notice that this effect, especially when we ask a patient to stop this therapy. So patient, in fact, sometimes no improvement in memory. You ask them to stop the acetylcholinesterase inhibitors, and you find that the behavioral and psychotic features return or increase remarkably. So usually our standard of care, when we find some patient with especially agitation or some type of aggressiveness, we start, or mild aggressiveness, we start with this type of therapy. Now, in case of severe cases, we prefer to send them for psychiatric input. Some cases are in fact intractable. Agitation and aggressiveness is not controlled by this type of medication, or even some milder types of antidepressant therapy like escitalopram or other medications. So we send them. And occasionally we give a trial for quetiapine for a short time to see, but usually this is an intractable case. Yeah, I think quetiapine is good. In milder cases, either the acetylcholine inhibitors or the, I think, antidepressant are effective.
Another question, what is the role of supplements in the treatment of dementia, such as ginseng, omega-3? Do we have any evidence regarding their efficacy?
I think there is some evidence related ginkgo biloba, other evidences, vitamin E, some evidences, but none of them is like very much robust. So, but I think for ginkgo biloba and vitamin E and some supplement, it deserves to be used as supplement, not as a treatment, but it's good probably as it having possibly neuroprotective effects. It's not in order to change the behavior of disease or even to improve the symptoms of memory difficulties or behavioral changes.
So it's very important to remind our audience that all these supplements usually do not undergo controlled clinical trials and are
Yeah.
not monitored by medication association or organizations such as FDA and EMEA. So those are food supplements who are not monitored. So be careful when using them or recommending them to your patients because, for example, ginkgo biloba can increase the risk of bleeding. Be careful if the
Yes,
patient is on
certainly.
anticoagulant, the interaction with their medications. So they should be used really carefully, and we do not recommend them if we don't have strong evidence about their efficacy. So another question, how long it takes for a medication to show its efficacy in Alzheimer's disease? So when you decide that this medication is failing and we need to shift to another treatment.
Usually, if you use the medication for 6 months or 4 months and you don't find any effectiveness when it comes to memory or when it comes to behavioral changes, it's better to move to another type of therapies. I'm talking now about symptomatic treatment, either memantine, Aricept, or galantamine, or these medications. So usually we do this. If there is no improvement in one of them, we move to other one. If there is again no improvement, sometimes we combine therapies. So many of our patients, we used to be on Aricept and memantine at the same time. So yeah, there are some evidence that there is some effect in delaying probably institutions related motor impairment, all this stuff, but it's not very robust evidence. Again, this is very symptomatic therapies. It doesn't give long-term control on symptoms. It is short-term control on memory or improvement, mild improvement in memory on some behavioral probably manifestations of the disease.
How can we stop Alzheimer's drug if we experience any side effect or lack of efficacy? Can we stop them suddenly or we need to gradually discontinue them?
For many of them, you can stop, of course, suddenly, and the patients sometimes our family stop the medication by themselves. They
Yeah.
found it is useless, so they stop it immediately. There is no rebound or reactions to stop these type of medications.
Is Alzheimer's disease considered an autoimmune disorder? This is a hot topic nowadays. So is it considered an autoimmune disease?
I think by definition, till just now, it's a neurodegenerative disorder. If you go one of the slide, I saw there was activation of microglia and astrocyte that is promoting, in fact, more probably uh, promote the activity of kinase and phosphatase in order to reduce the phosphorylated tau. I think it cannot be probably considered as inflammatory. There's still this moment, although there's some inflammation activation for microglia and astrocyte, but again, the dominant picture is a neurodegenerative picture.
Why Alzheimer is more common in America and Europe than in our Middle East region?
I think it is not more common or less common, again, because it depends on the capacity of detecting the disease and confirming the diagnosis. So I think in the areas like sub-Saharan area, it is very minimal as incident. Now you have to take into consideration that in sub-Saharan countries, the expectancy of age is around 50 or 60. So it's unlikely for patients to get Alzheimer at this age or dementias at this age. So it is, I think, more related to the capacity of getting or confirming the diagnosis. And again, it is related again for the life expectancy, okay, the average life expectancy. So whenever you find more incidents, it is usually that there is in this country good health system, the life expectancy is higher than other countries. Again, and the age of the elderly or the group of elderly patient is contributing to a huge part of the general population. So in European countries, you find that elderly is almost like contributing to 30% of the population of the countries. While in the areas like in the developing countries, you cannot find these figures, okay? So this is, I think, the differences is related not to the incidence and the prevalence. It is related to probably the life the life expectancy or age expected life, yani whatever, yani what the expected age of the patients or the population in the country.
How fast does Alzheimer's disease progress? How fast does Alzheimer's disease progress?
It is variable. Again, majority of patients goes to slow or moderate progression. It takes like years. Some patients get very aggressive behavior from early beginning to the degree that we sometimes doubt ourselves and we think that this is rapidly progressive dementia. We look for other causes. But again, some majority of them go slowly. It's not an aggressive disease. In very minor number, small percentage of the patient, it is aggressive from the early beginning, especially in the genetics type of early onset Alzheimer's disease.
If area H happened while using aducanumab and continued to macrohemorrhage, can the patient continue his medication since cranial bleeding is not compatible with aducanumab?
Excuse me, I don't understand the question.
So if hemorrhage occur as a side effect of aducanumab, can the patient continue the treatment or no?
No, if hemorrhage occurred, there's microbleeding. It's supposed to go through the severity grading as was seen or I saw in one of the slides. Okay, then whenever it is severe or there is hemorrhage, no, it is contraindicated. While it's microbleeds, it depends on the number, then on symptomatology and the decision of the treating neurologist. Usually, if it is mild to moderate and there is no symptoms associated with it, prefer to continue the aducanumab again infusion. If it's severe, no, it is just you have to wait or stop the treatment.
Taking into consideration the high cost of this monoclonal antibody, is it worth it to get it or to start it in patients, and especially that its clinical effects or benefit are yet to be verified?
I think here this is an ethical question and answers can go for all directions. In fact, the patient at this stage, early Alzheimer and early or mild cognitive impairment, still I think has to decide about himself. Still, he is having the insight enough to decide about treatment. Caregivers should be also be part of this discussion, and this is very difficult. The medical decision should be shared, and all information should communicate it to all parties in order to decide about start this treatment or not starting this treatment. Again, this is in fact worldwide discussion. It is ethical and medical, but again, it has a lot of ethical aspects should be discussed between all parties, including patients, including families, caregiver. So the decision should be made on very informed way by all parties.
How do we monitor efficacy of treatment in Alzheimer's? So what is the first sign that will be observed which show that this treatment is a successful one?
Till this moment, we have to go to the MRI and other imaging. If we have other imaging, BET for amyloid, BET for tau, or CSF. Again, as you find from PRIME study and from again the pivotal phase 3 study, they followed the scales, bedside scales like mini-mental status exam, or they follow the CDR-SB, and they follow the PET scans to correlate between the pathological clearance and the clinical improvement on this repeated questioning and the scales in every visit.
If there is any relationship between Alzheimer's disease and multiple sclerosis?
Yeah, I think but probably the question is there any correlation between multiple sclerosis and dementia in general?
Yeah.
The advanced conditions of and not very well treated of the multiple sclerosis may end by dementia and cognitive impairment. And we know there is some cognitive impairment in early even stages of multiple sclerosis. But again, this is not a typical syndrome of Alzheimer's disease. It's usually related to demyelination of the cortex in the brain. So it is demyelination lesions in the cortex of the brain of this patient that is the leading cause of cognitive impairment. It's not a deposition of amyloid and tau.
Does ketogenic diet improve Alzheimer's disease? Do we have studies?
I don't know.
If there is any interaction between memantine and antidepressants, so if a patient with suffering from Alzheimer and is maintained on an antidepressant can be also maintained on memantine?
I am not aware of any interactions between
there's no
these
interaction.
medications. Many of our, in fact, a huge sector of our patients of Alzheimer are on antidepressant, either escitalopram or Brentalex or other medications. So we don't, I'm not aware of any interactions, no.
The final two questions, can haloperidol be used for agitated Alzheimer patients?
As an acute agitation, it can sometimes be prescribed. We usually prefer not to give this medication. Again, we prefer to send the patient with aggressiveness, persistent aggressiveness behavior, intractable behavior, not responding to usual procedures like adding SSRIs or quetiapine or whatever to psychiatry input. Haloperidol is not a preferable medication to treat agitation on long term.
And the final question, can we use memantine to prevent Alzheimer's disease in a patient with family history and no symptoms, no dementia?
No evidence that this type of medication is preventing. It is just a symptomatic therapy that it give either neuroprotection, short-term neuroprotection, or improving the communication between neuronal cells in the brain, also again for short-term. But it's not changing the behavior of the disease. It's not preventing the disease.
Thank you, Professor Sha'ra, for this session. Thank you so much for staying with us until the end and for answering all the questions. At the end of this webinar, I would like to highlight that the approval of aducanumab underscores how investing in research can lead to better treatment option, but the drug is just one treatment. In fact, research for Alzheimer's disease and other dementias is significantly underfunded when compared to other diseases. There is an urgent need to invest in dementia research to provide people living with the disease new and better treatment options, and probably finding a cure for Alzheimer's disease and other forms of dementia. So our neurology expert researchers, you still have a lot to do in this field. Again, thank you, Professor Sha'ra, for supporting us tonight in raising awareness about Alzheimer's disease. Thank you, Biogen, for sponsoring this activity. And the big thank you goes for you, our attendees, for staying with us until the end. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar or would like to revisit the lectures, you can check our IVPN NeuroPsychiatry library where we post all the recordings. Follow us on our social media platforms and stay tuned for further discussions on Alzheimer's disease and for our next educational activity, which will be on Sunday, September 25. Save the date and keep your eyes on our page as all the details will be announced very soon. Until we meet again, stay safe and have a good night.
Thank you very much and having a good night. Thank you, everybody. Thank you.
Thank you.
Bye-bye.
Bye.